Good evening. My name is Jeff Smith, and I'm a haematology consultant based in Liverpool. And today I'm going to speak to you about primary CNS lymphoma. First of all, I'd like to thank Graham and Toby for inviting me and Lymphoma Action for this talk that I'm giving. So I'm going to cover the workup and the first-line treatment in the main. So first bit of background is primary CNS lymphoma is an aggressive malignancy of the brain, spinal cord, eyes, and cranial nerves. It's less than 1% of all the lymphomas that we see, and it makes up roughly 5% of all the extranodal lymphomas. Median age of presentation is usually roughly 65 to 70 years old, and the symptoms present quite quickly over the course of weeks with neurological symptoms. Most commonly a focal deficit such as a motor weakness, but it does include other symptoms such as neuropsychiatric in about a third of patients. Some seizures can occur, and a variety of other neurological symptoms such as headache, visual disturbance, confusion, etc. In terms of where it is throughout the CNS, most commonly within the brain hemispheres in up to 40% of cases, the meninges in about 16% of cases, but isolated leptomeningeal disease is quite rare, less than 5%, and about 20% of the time you get concurrent intraocular involvement. And it should be also noted that about 20 to 40% of the time the lesions are multiple throughout the brain. Just a quick note on primary intraocular lymphoma or primary vitreoretinal lymphoma. This essentially is a variant that can occur before, concurrent, or after diagnosis of primary CNS lymphoma. And broadly speaking, it's easy to say we just treat it like CNS lymphoma with a few additional considerations, particularly at the end. So this is just some images to show CNS lymphoma. These are two MRI scans of two different patients, really to illustrate the sort of ring-enhancing lesion that you can see, and also the degree of edema that can occur around the area of tumour, and hence the neurological symptoms dependent upon which part of the brain is affected. And the last image in the bottom right is just to show the white deposits that can occur at the back of the eye in primary vitreoretinal lymphoma, which can occur, as I say, with primary CNS lymphoma. Moving on to the histology, the majority of the time it is primary CNS lymphoma, it is diffuse large B-cell lymphoma. And over 80% of the time this is of the ABC phenotype, and more specifically on a genetic basis, according to the new classifications, the MCD or the C5 cluster. And this is relevant because you can see from the pathway down the bottom right, the genes that are mutated quite commonly in this type of lymphoma are the ones that are activated in the B-cell receptor, such as CD79B, MYD88, CARD11, etc. And this gives you a clue as to where some of the targets might be for the future as well. Obviously, there are other types of lymphoma that can affect the CNS, so T-cell and low-grade lymphomas also occur, but I say the predominant ones are those of a high-grade lymphoma, most typically a diffuse large B-cell lymphoma. In terms of the CSF, it is rarely diagnostic, perhaps at most 10 to 15% of the time, but if you are taking CSF samples, worth looking for cytology, flow, and IGH mutation detection, and also considering MYD88 mutation detection as well, which is, as I say, quite common in primary CNS lymphoma to be found. And the similar test can also be carried out in vitreal fluid to try and obtain a diagnosis and avoid a biopsy of the brain if necessary. In terms of staging, approximately 4 to 12% of cases which are presumed to be primary turn out to be secondary CNS lymphoma. And this is important because primary CNS lymphoma is stage 1E by definition, whereas secondary CNS lymphoma is stage 4. Moving on to staging, the relevant investigations that we carry out are obviously the MRI of the brain, followed up by a stereotactic biopsy of the site of concern, a diagnostic lumbar puncture, but again with the caveats I've just described, that it may not be diagnostic, and actually, although it perhaps should be done before a stereotactic biopsy, it typically is unhelpful. A staging PET-CT scan is very important because we need to know, is it primary or is it actually secondary? And that's where the PET scan can be very helpful. And allied to that is the use of testicular ultrasound in men to look for any evidence of testicular involvement. As we know, there's a very high risk in testicular diffuse large B-cell lymphoma of CNS spread. Lastly, ophthalmology examination is important by slit lamp, and this is again to identify the evidence of involvement of the eye, as this may change the management future down the line. The bone marrow aspirate and trophine is still listed as potentially a staging investigation. However, as with all other lymphomas now, generally speaking, we use PET-CT scan to determine if there's bone marrow involvement. And I would tend to reserve doing bone marrow tests in patients who have other concerns that has either been found on the PET CT scan, or, for example, if they have a paraprotein in their blood that might prompt you to do a bone marrow in addition. So just a brief note about steroids. Steroids are routinely prescribed to improve the performance status and minimize the risk of neurological complications when someone presents with a space-occupying lesion within the brain. Radiographic regression can occur in about 40% of patients, but this is not diagnostic, as it can occur in some other benign conditions such as sarcoid. So it's not a way of making a diagnosis, and a biopsy is still required. Ideally, we wouldn't give steroids before carrying out a biopsy, but as I said, this often happens, particularly in hospitals outside the neurosurgical centres, and therefore it's important that steroids are interrupted for at least a week before the biopsy to maximise the chance of obtaining histology that's interpretable. In terms of when we stop the steroids, generally speaking, we tend to continue them, although tailing them down over time until chemotherapy is started. And then when chemotherapy is started, tend to tail them off quite rapidly over perhaps a week, because at that point the steroids are likely to cause more harm than good, predominantly thinking around the risks of infection when on high-dose steroids. So this slide is really trying to summarize what I've said so far in terms of we take the information from the presenting symptoms, such as a focal deficit, the information from where the sites are, so is the disease affecting the hemispheres, corpus callosum, meninges, etc., and the neuroimaging features to try and determine whether we think this could be CNS lymphoma, and then based upon the suspicion, go ahead and organise a biopsy with our neurosurgical colleagues. And then assuming this comes back confirming it's a diffuse large B-cell lymphoma, then there's a variety of factors that need to be taken place to make us ultimately reach a therapeutic decision. So most notably, the staging that I've discussed. Other baseline investigations really to look at the patient's fitness, so around renal, hepatic, cardiac fitness, viral status, etc. And then lastly, although used less commonly now, the prognostic factors, so age, performance status, LDH, CSF protein, and deep regions can be used as a scoring system within CNS lymphoma to provide some prognostic information, although we tend to use this less commonly now with the current treatments that are available. I think probably the most two important ones of these really is your age and performance status, which are the ones that predominantly affect what treatment options you can use. So taking this all together, you then make a decision as to what treatment may be best or what to recommend to the patient. So moving on to treatment, I think the most important factors here really are, what is the goal? Are we looking to try and cure or palliate? And this will obviously be dependent on a lot of factors when you come to the treatment decisions. And then when we're talking about curative treatment, we're talking about induction chemotherapy or similar treatment, followed by consolidation. So I think it's important to note that performance status can be impaired significantly at presentation, and they can improve with treatment. So really decisions should be based upon physiology and not chronology. So by that what I mean is that if a patient was otherwise previously fitting well, it may be more appropriate to think of more intensive therapy than you might otherwise think of in other types of lymphoma. And I think it's important to note that because patients, the median age of presentation is age 65 to 70, this age group is probably the one that are most difficult to work out the level of fitness for intensive treatment. So I think patients who are less than 60, it is more obvious that typically we can give them intensive therapy, and patients who are over 75, it is less likely we're able to give them intensive therapy that's with a curative intent. But in the group of 60 to 75-year-olds, which actually makes up the majority of patients that we see, it's much more difficult and it needs to be fine-tuned according to their physiology and not just based upon a number. So in terms of induction chemotherapy, I think the first type really is the patient fit for intensive combination chemotherapy incorporating high-dose methotrexate? And by this, what I mean, largely speaking, is a regime called Matrix, which is given 4 cycles as per the RSU32 trial. It should be noted that this is quite toxic for certain patients, and the real-world data shows that 6% of patients end up in intensive care during the first cycle, and the TRM is up to 6%. And it's actually very common practice to dose reduce by 25% or more based upon age, comorbidities, or performance status. So just to illustrate the data from RSU32, these graphs show the progression-free survival and also the overall survival for patients. The purple line is Matrix, the blue line is methotrexate and cytarabine, and the red line is when rituximab is added. And you can see from this, by adding a combination of drugs called Matrix, which is methotrexate, cytarabine, rituximab, and thiatipa, then you can result in approximately 60% progression-free survival and a slightly higher overall survival. And this is the real-world data, which on the left shows similar data, slightly lower progression-free survival and overall survival compared to the trial, but overall largely similar data. However, on the right-hand side, the blue line compared to the red line is patients who would not have been eligible for IIC32 due to factors such as performance status, comorbidities, age, etc. And you can see they do significantly worse compared to the red line, which is patients who would have been eligible for the trial. And I think this illustrates that we have to be very careful in our patient selection, because patients who are fit for matrix can do very well, but similarly the same treatment in patients who are not perhaps eligible or fit enough for it can result in significant toxicity and impaired outcomes. So what's the other option? In terms of induction chemotherapy, we can think of it being not for intensive combination therapy, but still eligible for high-dose methotrexate-based chemotherapy. So by this, what I mean is that there's been a variety of phase 2 trials using methotrexate-based regimes, some adding oral alkylators, some adding other intravenous drugs such as cytarabine, thiatipa, and other drugs, etc. But a meta-analysis of 20 prospective and retrospective studies in patients with CNS lymphoma in patients aged over 60 demonstrated that high-dose methotrexate was associated with an improved overall survival compared to patients who did not receive methotrexate. However, there was no discernible benefit using intensive regimes involving intravenous drugs over high-dose methotrexate combined with an oral alkylator. This brings us on to data from a trial called PROMAIN, which was a combination of rituximab, methotrexate, and oral procarbazine. And from this, you can see that at 2 years, approximately a third of patients have a progression-free survival, with a slightly higher overall survival as a consequence, around about 50%. But the graphs on the bottom quite clearly show that there is continuing relapse over time, and the predominant cause of death in these patients is disease. So the next option really is, what do we do after we give induction chemotherapy, and assuming that they've responded to this. So consolidation is the next strategy that we use. This can be chemotherapy in the form of autologous transplant, and this is high-dose thiatipa based, not beam, and we would consider it for all patients in a partial response or complete remission from the induction treatment. The other option is radiotherapy, which is whole brain radiotherapy, and this would be thought of for patients who are ineligible for an autograft because they've got residual disease following induction, or because they've got residual disease following an autograft, or in selected cases, patients who are less than 60 who are in complete remission after chemotherapy that is methotrexate based, but in whom we're not proceeding to an autograft. And in this situation, whole brain radiotherapy remains contentious. There are risks and benefits to consider, and this really involves quite close conversations with your oncologist that delivers radiotherapy as to whether this be appropriate or not. So this is data again from the IIC32 trial, and this is the arms after induction looking at consolidation. And the consolidation strategy was a 1-to-1 of radiotherapy versus autograft, with a BCNU thiatipa autograft. And really I've put these up to show that there's no difference statistically in terms of progression-free survival or overall survival with either strategy. They were both, largely speaking, equally effective in terms of the progression-free survival. However, what I haven't put up is the data from the neuropsychiatric studies that showed that the neurofunction declined with time after radiotherapy, whereas it actually improved with time after autograft. And this is why we predominantly would recommend an autograft over radiotherapy, because of the long-term toxicity of the radiotherapy in patients that you're hoping to get into remission and potentially cure. So what's the third option? So the third option would be to consider chemotherapy consolidation. And recent data from the IC43 trial looked at 4 cycles of matrix, followed by consolidation with 2 cycles of Ardivik versus autograft. And what you can see from the graphs on the right is that people who received an autograft had significantly superior progression-free survival and overall survival compared to chemotherapy consolidation. Although even with the chemotherapy consolidation, there's still around about 50% progression-free survival. But the cumulative incidence of relapse is around about 41% with the Ardivik regime versus 16% with an autograft. So I think what this is telling us is that if patients are fit for an autograft, we should proceed with this. But however, if they're not, and we're not going for radiotherapy, I think chemotherapy, such as Ardivik, is still a valid consideration for consolidation, particularly patients in a partial remission post-matrix. So the last thing we need to talk about is palliation. Patients who are unfit for high-dose methotrexate-based therapy. What do we do with these? I think largely in this group we are talking about palliative therapy. We can use oral chemotherapy such as temozolomide or procarbazine, with perhaps a third of patients responding. We can give whole brain radiotherapy, which depends on the performance status and therapeutic aim, and can result in a very high response rate, even up to 97%, but the median survival is 14 months. So this is really treatment that we would deliver to try and palliate the patients with a life expectancy of perhaps up to a year, rather than a long-term strategy. And it's important to notice that the long-term side effects of radiotherapy are neurotoxicity, most notably dementia, ataxia, and urinary incontinence, especially in patients over 60, which is why, going back to the previous slides, we rarely consider radiotherapy in patients aged over 60. And the last thing we can do is also give patients corticosteroids as a way to control their symptoms, and dexamethasone is quite typically used in this setting. Quick note about primary intraocular lymphoma. As I said before, we treat it like primary CNS lymphoma, but a couple of extra considerations. If it's isolated to the eyes only and the patient is not fit for intravenous methotrexate, we can give intravitreal methotrexate and or intravitreal rituximab. And this can be critically useful for elderly patients, and it can produce disease control. CNS relapse is high, perhaps up to half of patients, but nevertheless it is a good strategy for patients. And bilateral orbital radiotherapy can also be used in this setting, an isolated disease, and also should be strongly considered as part of consolidation strategy when patients have finished treatment for primary CNS lymphoma with ocular involvement. So to summarize, patients who are fit for intensive treatment, and I've put patients who are roughly, say, age less than 65, but obviously that's very dependent on the patient. We would try to give them induction treatment with matrix, possibly with some dose attenuations, and then we try to provide them with an autograft for consolidation, with using radiotherapy as a secondary option, and in very selected cases, chemotherapy. In patients who are less fit, and they are typically aged over 70, we consider methotrexate-based regimes such as RMP, RMT, or similar. Again, it should be noted that these patients may have a reduced performance status at the beginning, and it's important to use a dynamic situation and review the patients as they go along, because it may be that the first cycle of chemotherapy is methotrexate-based, they improve their performance status, and they may even become fit enough to move to the left side of the graph, or left side of the table, I should say, and be considered for matrix-based chemotherapy, even at reduced doses. Assuming they do not go ahead to the matrix regime, then we would tend to give them maintenance procarbazine or similar. And I guess in selected cases, we would consider an autograft and a whole brain radiotherapy for consolidation. On the right-hand side, if there are patients who are not fit for treatment, we'd consider radiotherapy, oral chemotherapy, or steroids. So the other thing I want to talk about is novel approaches, which are used predominantly in the relapse setting, but can also be used in the upfront setting as well, and is coming along in the future. So first of all, BTK inhibitors. These are small molecules that penetrate the brain. And in some phase 1 studies, largely in the relapse refractory setting, such as in France, they do show significant efficacy with up to 75% response rate. And similarly, there have been some studies in America using a regime called TEDR, which again is using ibrutinib, including the frontline setting with high response rates. And I should also mention the current UK trial called PRISM Plus, which is using a drug called zanubrutinib in the relapse refractory setting. Secondly, I'd like to talk about IMiDs, particularly lenalidomide or similar. These drugs work through RF4 and 1 pathway, inhibiting NF-kappa beta, and therefore can interrupt the ABC B-cell receptor signaling, and therefore have some theoretical uses within CNS lymphoma, as they also penetrate within the brain, and there's some phase 1 data in the relapse refractory setting for these drugs. And thirdly, obviously we can't talk about anything without talking about CAR-T nowadays. So there's been a carousel study within the UK using CD19 CAR in the relapse setting. And it should be noted that in France, recent LOC data published in third-line setting demonstrated a 40% one-year overall survival. So though all of these types of treatment have been talked about in relapse setting, I'm sure as time goes by, they will move up within the treatment regimes. So to conclude, CNS lymphoma is a difficult group to treat. Careful staging and comorbidity assessment is required, and often patients start off with a poor performance status, and they're often commonly older population. We shouldn't underestimate toxicity of the protocols. As I said at the beginning, in the real world, 5 to 6% of patients do end up in intensive care, and a similar number TRM is noted as well. However, we do know that Matrix plus a BCNU thyroid autograft from the IC32 trial has resulted in a 70% 7-year survival. So we know this regime can be curative and should be regarded current as the gold standard, but also we've still got a lot of work to do. So in particular, we need trials in the older patients and also in the relapsed refractory setting to try and improve the treatments that we can offer our patients. Thank you.
Hello, everyone. My name's Chris Fox. I'm a professor of haematology at the University of Nottingham, and I'm a lymphoma clinician at the hospitals in Nottingham. Big thanks to Lymphoma Action and Graham and Toby for organising what looks to be a really great programme, running for many years now as our annual lymphoma management course in the UK. I'm going to talk to you today about two areas that are both rare and difficult. The first of which is relapsed primary CNS lymphoma, and the second of which is a rather different entity with some similarities, is secondary CNS lymphoma. These are my disclosures. So as you've just heard from Dr. Jeff Smith, we've made some great improvements in first-line therapy of primary central nervous system lymphoma. But even for those patients who are eligible for intensive therapy, and there are a number of studies here that I've referenced with the Kaplan-Meier survival curves, we still see a really early and devastating pattern of relapse for a significant proportion of patients. And depending what population you look at, depending which clinical trial approach is used, we're talking about at least a third of patients who will experience either relapse or progressive disease, typically within the first 6 to 12 months of initiating therapy, as you can see from this slide. And this is also true in the real world, and these are long-term population data from Nottingham, spanning nearly 4 decades, illustrating here 2 different eras of therapy. But the point really to make from this slide, similar to the clinical trial cohorts I showed you on the previous slide, is that the pattern of failure, so the patients who are destined to experience relapse or progressive disease following diagnosis with primary CNS lymphoma is typically early, so it's in the first year or 2. You do see late relapses, late and very late relapses. They're rare but recognised, but the big clinical problem is in the first year or 2 after first-line therapy. So what happens to a patient after the point of relapse or refractory primary CNS lymphoma? These are quite old data now from the French group. We've got a very well-organised national data base of primary CNS lymphoma. And so what you're seeing here on the curve on the right is survival data from the point of relapse, so patients who've experienced the relapse or progression event. And you'll see here, this is overall survival. You'll see here that, you know, a year after the point of relapse or progressive disease, you're looking at about 20 or so patients who are progression-free and about 30% who are still alive. So overall survival in red and progression-free survival in black. And so this is a big clinical problem. It's really difficult. Patients are typically impaired, both neurocognitively and in terms of their performance status at the point of relapse. By definition, their treatment experience, they have some treatment-related toxicities, and they're really difficult to recruit into clinical trials for some of those reasons, but also because of the issue of capacity to consent, and I'll come back to that later. And for all these reasons, there's really no uniform treatment approach. There's no accepted standard of care for relapsed primary CNS lymphoma. And an important point for us to consider that I'll come back to later is what treatment they've had as first-line therapy and how long that remission has been, if indeed they've achieved the remission. And so this is from the same data set from the French population based study, updated a couple of years ago in a bigger paper in neurology. And this is looking at, started with 1,000 patients diagnosed with primary CNS lymphoma treated in the real world setting, with this figure focusing on those patients who've relapsed or experienced progressive disease. And this really illustrates that how we approach the treatment of relapsed and refractory primary CNS lymphoma impacts outcomes. Not surprisingly, patients who have palliative care only have extremely short survival. Patients on the blue curve who have conventional chemotherapy without consolidation have a pretty poor survival. And you can see there with the increasing intensity of treatment and the use of consolidation, whether it's whole brain radiotherapy or hematopoietic stem cell transplantation with high-dose chemotherapy in red, and the survival improves. So how we treat patients second line clearly impacts on their survival. And in keeping with first line therapy, increasing intensity of therapy and consolidation is really important. However, it's really important to look at this population and say, well, what were these patients treated with in the first line setting? And actually in this big population-based study, nearly 80% of patients had not received any consolidation therapy first line. I'm sure that Jeff Smith in the previous talk has discussed how important this is, and particularly in the modern era, the use of Thiotepa-based autologous stem cell transplant. So in this cohort, most patients had not received autologous transplant, and only a minority had received whole brain radiotherapy. So these outcomes by treatment type may not be true in the modern era, at least how we approach primary CNS lymphoma. A number of years ago, we undertook in the UK a phase 1/2 study using the approach of a non-cross-resistant chemotherapy regimen, recognizing that most patients will have had high-dose methotrexate-based therapies in the first-line setting, and also recognizing the really impressive ability of Thiotepa, this small lipophilic alkylating agent, to cross the blood-brain barrier, and it's clearly very important in the context of first-line therapy and consolidation. When we set up the TIER trial, we didn't have those data, so we used it in the context of relapse. And really, this is just to illustrate 2 points. First of all, that even if you get high response rates, and we met the primary endpoint with an overall response rate of over 50%, the survival times were short. Secondly, to say that those patients who did experience long-term survival were those who hadn't received autologous transplant first line, but were able to proceed to autologous transplant in the second or third line setting within the context of this relapse trial. And then finally, to say that we set the protocol up and got ethical approval to allow to recruit patients who don't have capacity to consent. I think this is really important in primary CNS lymphoma. It's a big proportion of patients who have cognitive impairment due to their disease, and I feel strongly they shouldn't be excluded from clinical trials. And we've implemented that into a number of protocols since the TIER trial. Very briefly on this slide, just to say there are a number of studies looking at different agents. You see here over a 15-year period using conventional chemotherapies, antibodies, and even novel agents, which I'll come on to later. But on the right-hand column, the progression-free survival times are really disappointingly short. Even with those agents where you can achieve reasonable response rates, the durability of responses is really disappointing. So this is a really big problem that we're not doing very well with. Can we use biology to help us to try and point towards a pathway or a set of agents or a biological strategy to treat patients with relapsed primary CNS lymphoma? Possibly, I don't have time to go into the detail of the biology of primary CNS lymphoma, but it's quite genetically quite homogeneous. It's different to standard systemic DLBCL. And in particular, I'd point towards the very high rate of recurrent mutations in MYD88 that we see commonly in other lymphomas, notably Waldenström's macroglobulinemia, and other aspects of the B-cell receptor. So CD79 mutations are also common. And so this really pointed towards the potential use of using BTK inhibitors, which are very well established in a number of other, a range of other B-cell malignancies, which I'm sure you'll learn during the course. But in primary CNS lymphoma, ibrutinib clearly has activity. It crosses the blood-brain barrier, you get decent levels into the cerebrospinal fluid, and it has clinical activity. So on the right-hand panel of the slide was a French study using ibrutinib monotherapy, 52 patients, and over half of patients responding. And again, the disappointing aspect of the outcomes here is the relatively short, or the very short, really, progression-free survival. So most patients only having a response duration of a number of months. Lenalidomide is another example of a drug that has biological rationale in primary CNS lymphoma, and again is very well established in a number of B-cell lymphoma subtypes. And in this study, lenalidomide was combined with rituximab, the so-called R² regimen that we would use typically in low-grade follicular lymphoma, but with good rationale in the setting of primary CNS lymphoma. Similarly to the data we see with BTK inhibitors, relatively high rates of response. But unfortunately, you see there the pattern of relapse is continuous. So there's no plateau on the progression-free survival curve there. The green curve is the one to look at with the blue and the orange, the confidence intervals, and you just see a continuous pattern of relapse. There are a minority of patients who are getting clinical benefit over a reasonably durable period, but there's no plateau, there's no cure with this approach. And so just to really summarize on one slide, there are a number of BTK inhibitors and IMiDs, so the pomalidomide, a drug used in myeloma, similar to lenalidomide in its mode of action. Again, response rates which look quite promising, but then relatively short progression-free survivals. And similarly for the ibrutinib studies and the tirabrutinib study, which is actually licensed in Japan in this setting. But the field really then has moved or is moving towards trying to combine these agents. We see activity with single agent studies, there's biological rationale, but the durability of responses is short. And this is very early data, very small number of patients, again from the French group, who are very impressive in this field in terms of their delivery of studies and generation of data, showing quite promising response rates. Very early data, but just an example of something, an approach that the field is moving towards, particularly for those patients whose disease has relapsed early after intensive chemotherapy. And we have a study in the UK, and the PRISM study, which is open a number of sites around United Kingdom currently, and we are recruiting for patients with primary CNS lymphoma relapsed after at least one line of therapy, and using the second generation BTK inhibitor zanubrutinib. There are some potential advantages of this molecule over ibrutinib in terms of its pharmacokinetics and its kinase activity, but it remains to be seen whether it has any superiority in terms of activity, and most importantly, the durability of response that I referred to a number of times. So we recruited about 15 patients so far, and we're looking towards amending the protocol in the platform design to bring in partner agents with biological rationale. Don't think a single agent BTK inhibitor is going to be the game changer in primary CNS lymphoma, but it's a platform to allow addition or combination with other agents. So I encourage you to keep an eye out for this and refer any patients that you may come across to any of the 12 or 15 or so centres open around the country. I must mention CAR T-cell briefly, early data to keep an eye on, obviously very well established in systemic DLBCL, and you'll hear lots about this during the course in second and third line DLBCL, and uncertainty whether CAR T-cell therapy would be as effective in primary CNS lymphoma. We know that the T-cells can cross the blood-brain barrier. Again, the durability is a big question here. So some real-world data, some early studies emerging. My summary would be encouraging response rates in the order of 50%, not dissimilar to systemic DLBCL, but short follow-up so far. And I'm not yet persuaded that we'll see the durability of sustained responses that we see in systemic DLBCL. Real credit to Dr. Claire Roddy from UCLH, who led the Carousel studies. This is a UK-led study looking exactly this scenario of CD19 CAR for relapsed primary CNS lymphoma. This is now recruited, and the data are being analysed and prepared for publication. So this is another study to some data to add to the existing data for us to understand better how we can use the cellular therapies to improve outcomes in this rare and difficult disease. So just to summarise the first part of my talk, how do we approach primary CNS lymphoma that's relapsed or is refractory in current practice? Well, for younger patients, typically those who've been treated with the matrix regimen that Jeff has described, and often have had consolidation transplant with Thiatepa-based autologous transplant. These are really difficult patients. So if the patient has undergone matrix plus Thiatepa-based autologous transplant and had a short first remission, then they're a real problem. I think they're really chemotherapy resistant, and further chemotherapy is unlikely to gain much. What do we do in practice? Well, typically we would try and get a further response, and with chemotherapy, whilst planning towards whole brain radiotherapy. And we've really moved away from whole brain radiotherapy in the first line settings because of concerns regarding long-term neurocognitive dysfunction, which is significant. And I think that's the right approach. Nevertheless, whole brain radiotherapy is a very active therapy for primary CNS lymphoma, and I think it's a very useful tool in the armamentarium in the relapse setting. So we would try and induce a further response, maybe with a non-cross-resistant regimen like the R-ICE regimen, or if the patient's had a more durable first remission, we could go back to methotrexate. You can get responses in the second line setting, again with methotrexate, and this is different to systemic DLBCL, where we would rarely or never use the same chemotherapy agents again. But here, the most important intervention would be whole brain radiotherapy consolidation, accepting the attrition of medium and long-term neurocognitive dysfunction, given the survival expectations. Older patients who've often been treated with less intensive regimens, again, ask the question, what was their response duration to the first methotrexate-based therapy? And also in this group, could these patients be considered or reconsidered for more intensive approaches in the second line? Perhaps perhaps their physiological fitness and their performance status means that we could reconsider whether we could treat them more intensively, potentially with getting to autologous transplant. And we know that's effective in the second line setting when not received first line. So I think I always look at that as a question. But if an older patient's not fit for more intensive therapy, then really we're looking at palliative therapy. We'd always try and look for a clinical trial, and we've enrolled some such patients to the BTK inhibitor trials I mentioned. But again, whole brain radiotherapy is an effective option that we shouldn't dismiss. And yes, there are medium and long-term neurocognitive concerns, but survival expectations are quite short, and it has to be framed in that context. And so it might be, it's often a useful approach for this patient group. So we've got a problem with relapsed primary CNS lymphoma. It's quite a big problem. In the real world setting, over half of patients will relapse or progress, typically early, as I described earlier in the talk. Survival times are short. We need to think about the nature and timing of first line therapy, because that informs both prognosis and management options. And I've shown you some encouraging data from single-arm studies of the small molecule inhibitors informed by the biology, and also some preliminary data with CD19 CAR-T. But we're not really there yet in terms of durability of response, and I think there's a lot of work to do in the clinical trial and translational science space to try and make some more significant progress here. Okay, I'm just going to change gear quickly and move to secondary CNS lymphoma. So just an entirely different group of patients clearly with some similarities. The CNS is affected, so you have the commonalities there in terms of the clinical presentations and the treatment delivery challenges. The way to think about secondary CNS lymphoma is that there are three quite distinct groups, so three modes, as it were, of how this disease may present clinically. The first of which is synchronous, so you have disease both in the central nervous system and systemically, and this can be de novo, so first diagnosis, patient presenting with both central nervous system disease and systemic disease. Or you could have synchronous disease in patients who've previously been treated for lymphoma. So a patient perhaps who's had R-CHOP for systemic DLBCL and then relapses a year later with both disease in the central nervous system and systemic disease. This is probably the most difficult group because you've got potentially chemo-resistant systemic disease and the additional challenge of CNS disease. And then you have a scenario where you have systemic disease previously treated and the relapse is isolated to the central nervous system. So a patient presenting with a brain mass without systemic disease on PET a number of months or years after first line therapy. And we have to think about treating these patients differently, although because of the rarity of the condition, it's quite challenging to do clinical trials at all, and then secondly to do individual trials for these groups has proven really challenging. Should also say that CNS relapse only occurs in a minority of all DLBCL patients. So if you take all comers diagnosed with systemic DLBCL, it's probably no more than 5% of patients who would be destined to have a central nervous system relapse of some form following first-line therapy. When the disease does relapse in the central nervous system, it's quite commonly, nearly half of cases will also involve the systemic compartment as well, that difficult group I mentioned above. And survival times historically have been short. And this is demonstrated with a number of studies. This is a big retrospective study, nearly 300 patients, published a number of years ago now, showing that patients who experience any kind of secondary CNS lymphoma event following treatment with R-CHOP for standard systemic DLBCL, they have a very poor outcome. And you'll see there that the patients on the blue curve with concurrent systemic involvement at the time of CNS relapse have a worse prognosis than those with isolated CNS disease. Neither group does very well, but the systemic involvement is worse. And we took part in the UK, we took part in a phase 2 study a number of years ago, led by Kate Sinarski from UCLH, to whom I'm very grateful for providing me with some of her slides and insights in secondary CNS lymphoma. And you can see here from the Marietta study, which was published in Lancet Hematology a couple of years ago, that those patients who were treatment naive, who present for the first time with both systemic and central nervous system disease synchronously, they have the best outcome. That's the red curve on the right-hand panel. And it's perhaps not surprising. Their lymphoma has not seen chemotherapy. They're chemotherapy naive patients, and so there's a much lower chance of inherent treatment resistance within their lymphoma. What did surprise me from the Marietta study was that the patients with isolated CNS relapse in the grey curve they did less well than I expected. And certainly my experience of that patient group is better than that, and I tend to treat those patients with primary CNS lymphoma type protocols. I'm not going to go through the detail in this slide, but really just to say there are a number of prospective studies now in secondary CNS lymphoma that support the use of Thiotepia-based autologous transplant as consolidation. So however you get the patient into remission or to get to a first response, using Thiotepia-based autologous transplant, as we've seen in primary CNS lymphoma, really important in terms of outcomes. And this I think addresses the drug delivery through the blood-brain barrier. It addresses the drug delivery challenge in CNS lymphoma. High-dose Thiotepia, you're achieving nearly 100% of your drug levels that you see in the serum into the CSF and brain parenchyma. So it's probably the best conventional chemotherapy drug we have. So that should be the goal of treatment, as we see in primary CNS lymphoma in the first-line setting. The goal of treatment in secondary CNS lymphoma would be to get the patient to high-dose Thiotepia-based autologous transplant. And broadly speaking, approximately half of patients will do well. So you've got to get there. So these intention to treat transplant curves are always potentially misleading. So you have to look at both the left-hand part of the slide and the right-hand parts of the slide. So look at the whole trial to give you a picture of how the whole patient group fared with both remission induction and consolidation. And then the right-hand part of the slide shows you the progression-free survival of those patients who got to transplant. So by definition, they're a selected group. They've responded to treatment. They're fit enough for transplant. They've undergone transplant. So there's some selection bias there in terms of in that respect, but clearly getting there is important, and that should be a goal of therapy. So pretty good survival for those patients who get to Thiotepia-BCNE autologous transplant. This is from the Marietta study I mentioned before. And very briefly to say some interesting observations from this study. I showed you the curve on the left before earlier in the talks. Patients with chemotherapy naive, treatment naive, secondary CNS lymphoma did best. But on the right, we see an interesting observation that the compartment within the CNS, which is quite a complicated anatomical and physiological structure, where the drug delivery may be different between the CSF, the parenchyma, and the tumor. Patients who had the involvement of both compartments, both the leptomeningeal compartment and the brain parenchyma, seem to have a much worse outcome. And I don't think we really understand this observation yet. It's hypothesis generating. What about novel agents in secondary CNS lymphoma? We've talked about BTK inhibitors and lenalidomide in relapsed primary CNS lymphoma. Well, of course, these agents have been used in both systemic DLBCL and clearly have been investigated in secondary CNS lymphoma. Some interesting data from the NIH group, Mark Rajewski in Bethesda, working with Louis Stout and Wyndham Wilson, showing that patients with secondary CNS lymphoma who respond initially to ibrutinib, again, relatively high rates of response, but then go on to have a CNS-directed chemotherapy regimen, do much better than those patients who don't respond to ibrutinib at all. So it's a small study, again, hypothesis generating, often potentially selected patients within this tertiary center in the US, but an interesting observation and really showing us that we need to learn a little more about how to combine novel agents with chemotherapy. So ibrutinib has been tested, lenalidomide, again, a recurring theme here, based on both the biology and the data in systemic DLBCL, showing promising activity. But similar to the relapsed primary CNS lymphoma story, really a single agent's pretty insufficient in terms of durability. CD19 CAR-T, talked about this a little bit. You've heard lots about it in systemic DLBCL. Some of the patients in CD19 CAR-T systemic studies did have secondary CNS lymphoma at the time of infusion, and we were seeing response rates of around 50%. This is a study looking at a larger group of patients in the real-world setting, and patients post-license who've been treated. And you'll see here that it looks feasible in terms of the toxicity, so not greatly different in terms of CRS and ICANS that we would see in systemic DLBCL, encouraging response rates, but you'll see there at the bottom, the median duration of response is pretty short. And again, the key question will be here are those patients who respond, what's the durability? And is it because of lack of persistence of the CAR in the CNS? Is it because of a different immune evasion story? And there's certainly differences here with primary CNS lymphoma at least. Or is there another mechanism of resistance that's different to systemic DLBCL? I realize I've packed quite a lot of data and a number of different concepts into this talk. So this is one way to think about secondary CNS lymphoma, and this is taken from Kate Sanarski and Jantabib Kajwa's really great educational piece recently published. To think about secondary CNS lymphoma in the sense that I described earlier on, the three modes of presentation: de novo, synchronous or concomitant presentation, isolated CNS relapse, or synchronous relapse. And I won't go through the slide in detail, but suffice to say that the difficult group is those with synchronous relapse. And I think this is where CAR T-cell therapy could be really important because of its activity in systemic disease and its ability to get responses in the CNS. For patients with isolated CNS relapse, in principle, a primary CNS lymphoma type protocol seems to offer, at least in mine and others' experience, the very good chances of long-term remission. And as I said, the outcomes in the Marietta study were disappointing. I don't know what the value of RICE is in this group. And for patients, perhaps the best prognosis group, the de novo patients who present for the first time in both compartments, then we tend to follow the Marietta protocols. This is matrix, RICE, and a thiotepar-based autologous transplant. There are smaller data sets showing potential value of the orthodox MRI, like Burkitt regimen, but that's less strongly evidence-based. I think overall, the goal of treatment for those patients who are fit enough is to get to a thiotepar-based autologous transplant. And I'll stop there and thank you very much for your attention.
Hello, I'm Kate Sanarski, and I'm a haematologist at University College Hospital London, and I lead the T-cell lymphoma group in the UK, and I'm going to talk about challenges in treating patients with T-cell lymphoma. So I'm going to focus on nodal, extranodal, and leukemic T-cell lymphomas, and I'm not going to talk about cutaneous T-cell lymphoma in this talk. I'm going to talk about the role of transplant, the treatment of relapsed refractory disease, and hopefully highlight some potential future strategies. There are about 1,400 patients with T-cell lymphoma that present each year. In the UK, so Europe and North America, the majority of patients have either PTCL-NOS, and immunoblastic T-cell lymphoma, in about 20% of cases, anaplastic large cell lymphoma. This is in contrast to Asia, where there's a much higher proportion of patients with ATLL or NK T-cell lymphoma. Now you can see here, I've tried to highlight some of the differences when the WHO reviewed things in their 5th edition published last year. Really, there's very much that's the same, but really the focus of these T follicular-like type of lymphomas, and that's also duplicated in the international consensus classification published also last year in Blood. You can also see how some of the molecular subtypes are being identified, and these are coming into both classifications. Now, this is sort of historical real-world data, but I will show you in subsequent studies that really this very disappointing outcome for the majority of patients is seen. So in the non-ALCL setting, so PTCL NOS and angioimmunoblastic T-cell lymphoma, only a third of patients are alive at 5 years, and the majority of patients will have relapsed refractory disease. There are a number of different prognostic models. Sometimes we use modified IPI. You can see the other parameters used, including things like Ki-67, whether there's marrow involvement, etc. But the major challenges are really due to a number of different reasons: rarity, but also the significant heterogeneity, as well as inherent chemo resistance that I've mentioned. So, in the majority we don't see durable remissions. We do know that most trials have included all subtypes. There have been few randomized control studies, and historically CHOP has been the standard, and it's still a backbone to add new agents in prospective studies that are described. In terms of conducting phase 1/2 studies for ultra-rare biologically defined entities, this is challenging and certainly does require international collaboration. Now, as I've outlined, the majority of patients will have PTCL NOS or these T follicular-like lymphomas. And I'm going to sort of talk about a 50-year-old man with PTCL and a 70-year-old man with angioimmunoblastic T-cell lymphoma, and sort of highlight important parts of the data that influence my treatment decisions. So one of the questions really is there anything better than CHOP for this cohort of patients, and can biology influence and direct our treatment decisions? When I stage a patient with T-cell lymphoma, I have a low threshold to perform a bone marrow. I may be considering autograft consolidation, and PET in T-cell lymphoma appears to be a bit less reliable. I've already outlined the poor prognosis, and the question really is, what's the merit of adding etoposide? What's the role of autografting? And I'll highlight this in subsequent slides. So there are no trials directly comparing CHOP with CHOEP. This is data from 7 different phase 2 or 3 protocols from the German high-grade non-Hodgkin study group. And here you can see it looks like the addition of etoposide may be beneficial. But the important bit is this is in younger patients, particularly ALK positive, when we now have brentuximab. So in reality, I don't use etoposide in my frontline setting unless somebody has concomitant HLH. You can see the South Korean study in older patients, there was no evidence that the addition of etoposide was beneficial. Now I'm going to use some slides from my colleague Pierluigi Zinzani, who did a Meet the Professor session at ICML recently. As he's outlined, we have a number of studies that have identified that we don't have anything better than CHOP. The chemo-T study highlighted in the top left, where GEM-P was compared to CHOP, led by Mary Gleason and David Cunningham, was a negative study. I mean, there was nothing better than CHOP, even though the outcome was still disappointing. There have been a number of CHOP plus X strategies. We've outlined a number of drugs in the middle box, and I'll talk about the addition of an HDAC inhibitor. The question is, in some of these T-cell lymphomas, so this T helper type lymphoma, will there be a role for novel non-chemotherapy backbones, demethylating agents, HDAC inhibitor-based regimens? And I'll also talk about this in subsequent slides. Now, this was a really impressive study. It was published in JCO in 2021. It was led by the LYSA group, but it was a prospective study in patients with untreated PTCL. You can see it involved 9 countries, 98 centers. And the reality of it is it was a negative study. There was no improvement either in PFS or overall survival in the patients who were randomized. So there were 211 who received ROCHOP and 210 who received CHOP, and very similar outcome in both. However, at ICML very recently, the French group were able to follow up these patients at 7 years and look after central review of the pathologies, identify those patients with a T follicular helper-like phenotype, and identify in these group of patients their outcome. You can see on the left where this T follicular helper subgroup of patients, that those who received the addition of romidepsin had a median survival of 19.5 months, while those who received CHOP, it was 10.6 months. While on the right-hand curve, the non-TFH type, the median survival was less than a year in all. So this hint of a prolonged response in this T follicular helper group. Now, we often ask the question, do we need to perform an autograft up front? What is the role? And is this a treatment modality we should be offering to all patients? This was the first study really that was assessing this question. It was published by the Nordic group in 2012 in JCO. It was an autograft, potentially fit cohort of patients. You can see that only 115 of the 160 patients actually got to transplant because of the reality of patients progressing during first-line therapy. And even those who received this CHOEP ×6 plus beam autograft, the overall survival at 5 years was around 50%. Now, a number of groups have tried to look at their data sets to see retrospectively, is there a role for consolidation autograft? But both the complete registry and the LYSA analysis showed no statistically significant differences in outcome. But this was a study published in Blood last year. We have both landmark analysis at 9 months of all nodal PTCL and also those who had achieved complete remission. And their conclusion was that consolidation with autograft in the first-line setting did significantly improve overall survival in patients with ALK-negative ALCL, angioimmunoblastic T-cell lymphoma, and PTCL NOS. Now, can we identify those who will benefit most? I think in the future, we may use interim imaging, baseline total tumor, metabolic tumor volume, minimal residual disease evaluation with ctDNA, and other predictive biomarkers. But in summary, I think we have to be clear that there are no randomized clinical trials. The LYSA group are really impressively conducting a prospective randomized trial, and there's retrospective evidence presently for and against. As I've mentioned, there are few prospective trials and they have diverse subtype inclusion. But I would agree with Professor Zinzani that because the relapse risk remains high with CHOP-like chemotherapy alone, I do consider this treatment option in most subtypes, with the exception of low IPI ALK-positive ALCL. So, for example, for this 50-year-old man, I would be giving CHOP and aiming for an autograft because the treatment options in the relapse setting are really dismal, which we'll talk about. With angioimmunoblastic T-cell lymphoma, I have a number of other treatment possibilities. The risk as someone gets older of an autograft up front becomes higher, so I would choose to observe this patient. I've also chosen to give CHOP on a 2-weekly basis in this 50-year-old man. I think that's just getting to autograft earlier, but there's no data to say superiority of a 14-day cycle of CHOP compared to 21 days. I'm now going to talk about anaplastic large cell lymphoma. We know there's a bimodal age distribution, with ALK-positive being more common in younger patients, ALK-negative more common as people get older, and you can see here the gender disparity much more common in men. We know that initially ALCL was defined by CD30 expression, and we also have these hallmark cells which are characteristic, large cells with horseshoe kidney-shaped nucleoli. ALK expression most commonly is underlined by the translocation 2-5. Now, there's some really conflicting data about the importance in the ALK-negative cohort of patients about DUS22. In some studies, it suggests that those patients who have evidence of DUS22 to have a better outcome, but I don't think we have robust concordant data. So it may influence your decision to autograft, but I think we still have to say that there's some heterogeneity within the data, but certainly P63 is a marker of a very poor prognosis. So in terms of brentuximab, you know this from your Hodgkin's talks that, this is an antibody drug conjugate binding CD30 associated with MMAE, and the randomized phase 3 study ECHELON-2 really has changed how we treat patients with ALCL. It was this large randomized study. You can see here that we had more than 150 patients in each arm. 70% of the cohort had ALCL. This was first-line therapy, and there was both an improvement in progression-free survival and overall survival. And certainly this really did influence the NICE decision to fund this, and this is our standard of care now. I do certainly use preemptive GCSF. I monitor for peripheral neuropathy. I think it's helpful, as we do with patients receiving Christine, to review any evidence of peripheral neuropathy at each cycle. And of course, the important question is, do you need to dose reduce or even omit brentuximab? Certainly, this is a side effect that we see more commonly in patients as they get older, but generally reversible. So I'd like to talk about a patient we've recently treated, a 42-year-old woman who had widespread bony involvement and a left renal mass, stage 4B out negative ALCL. Her performance score was 2 prior to therapy. She had a raised LDH. We gave her BV chip with curative intent. And the question was, do we have any more data in the setting of ALCL to influence our treatment for patients about autograft in CR1? Now, this is further data from the ECHELON-2 study. It was looking at patients who had ALK-negative ALCL, who'd achieved complete remission, and whether they were autografted or not. If you look at the bottom left, you can see in terms of intention to autograft, certainly less enthusiasm in Asia, at only 13%. Certainly outside Asia, half the physicians said they would aim to autograft, but you can see this results in the numbers being quite small. So only 27 patients had an autograft, only 49 no autograft in this setting. And you can see the numerical superiority, so an improvement in progression-free survival from numbers, although this didn't reach statistical significance. But certainly it's helpful if you want to consider an autograft that this data does support that decision. But we also have to be realistic. In the real world, less than 10% of patients with ALCL will proceed to autograft. It's partly age. A lot of people will be over the age of 65, over the age of 70, which may influence decisions, but I think that is the reality. This was data from our Nottingham colleagues. So we did autograft this patient. This patient did remain in complete remission, and she still does. And it is consistent with our BSH guideline, where we do consider autografting in this setting, as well as in patients with ALK-positive ALCL with a high IPI or older patients. If patients relapse, then we may consider brentuximab with or without chemotherapy, but really thinking about potential allografting in that setting. In some situations, in ALK-positive ALCL, we may consider autografting, but often if you're chemorefractory, the merit of autograft in T-cell lymphoma is less evident. I'll briefly mention breast implant-associated ALCL, associated with textured breast implants, and early diagnosis is crucial, because surgical resection could be curative. We could use PET in terms of staging, and if patients have advanced stage or a mass, potentially considering other treatments as we do in ALCL, but I would urge you to look at our UK guidelines recently published. So what about if either of these patients relapse? What potential treatment options do we have in the relapse refractory setting? And I think it's been really helpful at ICML, our colleagues from the LISA group presented their follow-up data looking at patients who had relapsed refractory disease and treated in the last decade. So as I mentioned, 421 patients were recruited to the study, and you can see that 251 patients, the majority of patients, received second-line therapy. You can see really there's no standard of care. Any of these second-line treatments were actually given to less than 10% of patients, and other is seen in more than 50% of patients. That's the box on the right, where you can see there were just less than 10 patients treated with any of those approaches. The median age of patients was 66, again, influencing potential consolidation strategies. So the thing it did tell us is that really the outcome when you treat someone second line, their median progression-free survival was 3.3 months, really sort of dismal figures, and median overall survival of less than a year. Again, though, the T follicular-like tumours, as noted on the right-hand side, their median overall survival was over 18 months, while all others less than a year. So again, another signal for this cohort of patients that may respond to other lines of therapy, which I'll mention. The thing that was helpful as a reminder from this data is, as I've mentioned, 251 patients required second-line therapy, but only 14 got to allograft, only 21 to autograft. So although these consolidation strategies may grant durable remissions, it's a highly selected subset of patients. The issues will be as I've mentioned, the median age is 66 years, so older age will preclude these treatment modalities, but also chemosensitivity is also an issue. Then the question is, what second-line therapy? We use GDP. I can't say it's any better than any others, but the data certainly supported this approach, which is more in the outpatient setting, and we will continue to do so. I just want to focus a bit on follicular helper T-cell lymphomas, which I've really mentioned a lot, occur in older patients, frequent autoimmunity, frequent extranodal involvement, historically a poor prognosis, and previously few therapeutic progresses. I think what's helpful is there is really a homogeneous mutational landscape. So the evidence of TEC2 mutations, the RHO-A mutation, and DNMT3A. So again, throughout all of these, evidence of this is really helpful when we think about biology. There have been a number of studies from phase 1 and 2 studies suggesting an epigenetic susceptibility, so with HDAC inhibitors, demethylating agents. And this led the LISA group to conduct the Oracle study, which we also participated in the UK. So this is using oral azacitidine in one arm versus what was considered a standard of care. In the UK, it was really gemcitabine, but other places could use bendamustine or romidepsin. And although the study didn't meet the primary endpoint, this was partly because of relatively ambitious statistics, but we did see a prolonged overall survival in those patients who received the oral azacitidine, so a potential agent to consider. Now, I've highlighted here different classes of agents. So certainly trials that I would want to participate in are those using PI3 kinase inhibitors, certainly in the ALK-positive tumors, the ALK inhibitors. We have patients who have been enrolled into the valemetostat study, the Valentine study of an EZH1/H2 inhibitor. Also, I've mentioned hypomethylators and also HDAC inhibitors. But when I mention this, I mention it in the setting of clinical trial because to date, approval of drugs in Europe has really been disappointing. And I don't have access to romidepsin or an HDAC inhibitor or even an ALK inhibitor within the NHS setting. They haven't been approved for marketing within Europe. Now, I'm going to mention a lady really where it's really highlighting how clinical trials and access to novel agents can really transform the outcome. This is a lady with angioimmunoblastic T-cell lymphoma, so T follicular-like, who was refractory to CHOP. And as I've mentioned from the RHO-CHOP study, really an outcome that you would think of as in terms of measured in months and sort of less than 2 years. But this is a lady who she had access to romidepsin on the ROMACAR study that was led by Graham Collins. She didn't want an allograft. She then progressed. We managed to access lenalidomide, a CELMoD, on compassionate access, which she received for 3 years. And then she's been receiving valemetostat. She remains in complete remission more than 12 months. And we've also identified she's TRBC1 positive, which I'll talk about in terms of potential access to CAR if she should relapse in the future, but really highlighting the importance of can we access some of these agents, whether it's in the clinical trial setting or on compassionate access. What about the immune system? We know about the impressive change in outcome when we've accessed CAR-T in aggressive B-cell lymphomas. Certainly, checkpoint inhibitors, there's been some evidence of hyperprogression in T-cell lymphomas. The issue with CAR is that to date, PTCL has not benefited from immunotherapy because pan-T-cell depletion is highly toxic, and there are few or no tumor-specific antigens from PTCL. I'm just going to have a couple of slides on a phase 1/2 study that we've led at UCLH, which involves a CAR T directed to TRBC1. And this is on the basis that the beta chain of the constant region of the T cell receptor is duplicated. So the healthy T cells have a mixture of both. A tumor is clonal. So if you have a TRBC1 positive tumor and a TRBC1 positive CAR, you will kill both the healthy and tumor cells, retaining TRBC2 normal cells and some immunity. So it's still dose finding, trying to find a dose, but to date, no ICANS, and only 1 of 13 patients who've had grade 3 or more CRS. And 4 of the 4 patients treated at the highest dose have achieved a response, 2 remaining in CMR. And really, this is one of our patients who was referred to us, a person with angioimmunoblastic T-cell lymphoma, CHOP, ice-duvelisib refractory, and at 18 months remains in remission. So interesting data, potentially. I'm now going to just talk about extranodal lymphomas, NKT cell lymphoma, as I've mentioned, much more common in Asia, really important for both MRI and PET in the staging, and EBV. So EBV PCR and the stage, really important in terms of determining the treatment. And you can see here in terms of molecular pathogenesis, really a lot of evidence of chemoresistance. As I've mentioned, really from MRI and EBV PCR, is there evidence of localized stage disease or advanced stage disease? And that will determine, is there a role for radiotherapy in localized stage disease at the dose of more than 50 gray? Often takes time to plan radiotherapy. So we often start with a regimen such as Gelox. And Gelox is a regimen which includes a platinum, so it's like Gemox, but the pegylated asparaginase is added. So it's those 2 agents are really important. So we give 2 courses of Gelox, radiotherapy, then a further 2 courses of Gelox. In advanced stage disease, again, DDGP is a combination of GDP with the pegylated asparaginase. I'll show you in the next slide about why we choose this rather than SMILE. But again, we ask the question, should we allograft in CR? Should we autograft if patients have advanced stage disease? There's no randomized data, but certainly patients who relapse, it can be a really challenging situation. We find it hard to access anti-PD-1 agents, even though there's definite evidence of efficacy in this disease. So this has not yet been published, but has been presented at ASH, a multi-center phase 2 study comparing DDGP and SMILE. You can see DDGP less toxic and certainly appears to be more efficacious, reflecting our approach to use that. And I'm just going to mention a few other rarer entities. So ETL, much more common, as we know, in patients who it's associated with celiac disease, really important to manage with a gastroenterologist and nutritionist. METL, that's not associated with celiac disease. In terms of treatment, we use the Newcastle regimen, where it's CHOP, then IV methotrexate getting to beam autograft. And Anne Leder's prospective phase 2 study showed encouraging data in older patients who are non-transplant eligible, potentially using CHOEP. Hepatosplenic T-cell lymphoma, this is rare, mainly affecting young adult males, involving liver, spleen, and marrow. Marrow is really important here. We use an ifosfamide-containing regimen aiming to get to allograft. And you can see from this data that Nehameta Shah presented at ASH in 2020, 34 patients with hepatosplenic T-cell lymphoma and 2-year progression-free survival exceeding 50%. Now, I'm briefly going to mention ATLL. I've treated many patients with ATL, but I always check in with Lucy Cook, who's our national expert, and I do check HDLV1 in all my T-cell lymphomas. So again, it's really helpful to look at the phenotype. Is there monoclonal integration of HDLV1 proviral DNA? And being aware of the increase in opportunistic infections and checking strong galoidal serology, treatment of seropositive cases at diagnosis. Really thinking, could this patient be a potential allograft recipient, and referring promptly at diagnosis. I tend to incorporate cytopheidine and interferon alpha with CHOP, with GCSF, and thinking about certainly IT therapy, so prophylactic CNS therapy. And the question is about the addition of high-dose methotrexate in those who have other risk factors, such as significant numbers of extranodal sites. If you can't get to allograft, the question is, could you use some sort of maintenance strategy? And again, can you access a monoclonal antibody, which is most effective in the leukemic? But again, I discuss these cases with Lucy Cook. I'm just going to mention this man who presented in 2021 with this blood count. He had just isolated splenomegaly, This was his flow cytometry saying a CD2, 3, 5, 4, and 7 positive population. He had T, PLL. And again, can you watch and wait? But patients often present with a significant leukocytosis, cytopenias, splenomegaly with or without some lymphadenopathy. Having a low threshold in that setting to think about Campath, aiming for allograft, and being really aware that Campath is really immunosuppressive. So thinking about the T cell depletion that this is going to provide. So I add an antifungal weekly CMV PC monitoring to the acyclovir. Now, some patients can be relatively refractory to this. So maybe after 6 weeks of this, where we don't see the lymphocyte count reducing, I may consider the addition of pentostatin. So finally, T cell LGL, again, median age in your 60s. This is really defined by persistence, so more than 6 months of clonal expansion of circulating LGLs, and really thinking about indications for treatment are because of cytopenias, most commonly neutropenia. So if there really aren't any cytopenias I would watch, if there are cytopenias, I'm then thinking about agents such as methotrexate, cyclophosphamide, or cyclosporin, and being really thoughtful about the fact that time to response can be slow, so I don't sort of bail out too early. I treat for at least a minimum of 4 months before determining the quality of response, and then again thinking about second line. So Dima El-Shakari at the Marsden has a particular interest here, and again I would check in with her if I found a patient was refractory or had relapsed. Are there any clinical trials in that setting? Now, this is an algorithm prepared by my colleague Pierluigi Cinzani. Really, this has been published recently in Hematology Oncology, and it was presented at ICML. You can see here, autografting there really being quite central. What's the evidence base for this? Being aware that in certain situations, as I've mentioned, low IPI, ALK positive ALCL, we don't. And then the question about certainly in those with hepatosplenic, thinking about allografting. I think it's interesting that he added azacitidine in the angioimmunoblastic in the frontline setting. We certainly can't access this for the minute. In summary, this really is an area of unmet need. We do need innovative treatment approaches. We really need to think about disease biology, molecular mechanisms, and we need novel treatment platforms. This one-fits-all approach doesn't work in PTCL, and we really need to identify and target the specific subtypes and international collaboration. And I'm really grateful for working within the UK T-cell lymphoma community. Just, we often get asked about tricky patients, and it's really helpful to sort of discuss it with my colleagues. I'm always happy to be contacted, but we do need more trials in this setting. And certainly I'd like to think that certainly before I retire, we see an improvement in outcome, because I really haven't seen this in the last 20 years. Thank you very much.
Thank you for inviting me to speak at this year's Oxford Lymphoma Management course. My name is Andrea Kühnel. I'm a consultant hematologist at King's College Hospital in London, and I will speak about harnessing T cells to treat lymphoma. So you will hear most of the results from the clinical study of these therapies in the disease-specific talks, but this talk is supposed to provide a little bit of background. So the most relevant T-cell directed therapies for lymphoma are as shown on this slide. So we have allogeneic transplant, where we see an anti-lymphoma effect from alloreactive donor T cells. We have anti-PD-1 and PD-L1 antibodies such as nivolumab and pembrolizumab, very important therapies in classical Hodgkin lymphoma treatment. So these antibodies block inhibitory checkpoint pathways and thereby reactivating endogenous anti-tumor T cells. But today we will really focus on CAR T cell therapy and bispecific antibodies, the two T cell therapies that have really transformed the treatment landscape in lymphoma in recent years. So CAR T cells are antigen-specific adoptive T cells. The T cell is genetically modified to express a recombinant CAR receptor, in this example against a CD19. And bispecific antibodies attract and engage endogenous unmodified T cells through a CD3 domain and have a second domain, in this example CD20, binding to the lymphoma cell. So let's start with CAR T cell therapy. CAR stands for chimeric antigen receptor, And the structure of this receptor lies in the name. So chimera is a creature made up from 2 different animals, and similarly a CAR is an artificial construct combining 2 different elements, an antigen binding site and a T cell activating domain. And this is the basic structure of all CARs, but these first generation CARs have been further developed and advanced. Second generation constructs contain a co-stimulatory domain to increase T cell function, for example, CD28 or 41BB. The licensed products we currently use are all second generation CARs. Third generation CARs have a second co-stimulatory domain, and fourth generation CARs, so-called armored CARs, not only express the CAR, but an additional protein such as a cytokine or an antibody to increase cell function. It's important to be familiar with the CAR-T pathway a patient has to undergo for this treatment. So usually patients are selected and deemed eligible, then referred to a commissioned CAR-T center. Treatment is approved through the National CAR-T Clinical Panel. This centralized approval structure is quite unique to the UK. Patients then undergo leukapheresis. The starting material is shipped to the company that manufacture the cells, which takes around 4 weeks, during which we often consider bridging therapy to stabilize the disease, and then the final product is reinfused. It takes around 8 weeks to CAR T cell therapy, so the vein-to-vein time from leukapheresis to infusion is 41 days from our UK data set, but the overall so-called brain-to-vein time is around 58 days. Let's take a closer look at the manufacturing process. So we collect peripheral blood mononuclear cells from the patient. T cells are selected and activated. They're incubated with a retrovirus or lentivirus containing the CAR gene. Cells that are successfully infected or transduced then express the CAR. Cells are then further cultured and expanded, undergo quality control until the final product is reinfused to the patient. This final CAR-T product is a medicinal product, but different to other medicines, very heterogeneous depending on each patient's individual starting material. And there has been a lot of work to investigate these inter-patient differences and the diversity of cells and cell clusters within one product. What we know from these studies is that an enrichment of CD8 memory T cell phenotypes confers a better outcome, whereas an enrichment of T cell exhaustion signatures is associated with worse outcome. This study looked at the axi-cell product characteristics in patients treated on the ZUMA-1 trial. So this was the pivotal study that led to approval and licensing of third-line axi-cell. And what they saw is that responding patients had a higher p-CAR-T level and a better cell fitness. They identified specific T cells to be associated with cell fitness and response. So at least for axi-cell, from this study, we know that the main anti-lymphoma effect occurs early in the first 2 weeks, and cell persistence is not needed to achieve response or maintain response. And efficacy is driven by these specialized T cells associated with higher cell fitness. Now, how could we potentially improve CAR-T fitness if that's such an important parameter? Now, we could use CAR-T cell therapy earlier in the pathway. This is data from ZUMA-12 using axi-cell in the first-line setting, where they showed that patients had a higher cell expansion and cell fitness compared to ZUMA-1, so the third-line setting. We should also avoid lymphodepleting chemotherapy prior to CAR-T, such as bendamustine. So this is data from the Spanish group presented at ASH last year, where they demonstrated that patients with large B-cell lymphoma who received bendamustine prior to apheresis had lower durable response rates. Armored CARs are aiming to increase CAR fitness by secreting pro-inflammatory cytokines. And there are studies combining CAR with checkpoint inhibitors in order to delay cell exhaustion. If we use allogeneic CAR, so CARs generated from healthy donor who did not undergo chemotherapy, this obviously generates fitter cells, but this approach comes with other disadvantages. So what we often see in the CAR-T setting is a transient response. So we have very impressive overall response rates of 70 to 80% of patients, but only half of these responses are durable. The different mechanisms of resistance have been identified to account for this, such as antigen loss through mutations or alternative splicing. This is supposed to account for 30% of large B-cell lymphoma refractoriness, but is more relevant in the ALL setting. We can see tumor pathway alterations such as apoptotic pathway defects, and very importantly, niche protection by an immunosuppressive tumor microenvironment. Now, one way of potentially counteracting CAR-T resistance is with bridging therapy. So we have now quite good preclinical data to suggest that radiotherapy bridging has a synergistic and priming effect to CAR-T, so really modulating this immunosuppressive tumor microenvironment. We have data to suggest that there is a positive effect of debulking through effective bridging therapy, so to prevent early exhaustion of the cells, to optimize the ratio of specialized T cells to tumor burden, and clinical data from our group to show that patients who responded to bridging had better outcome compared to non-responders. And finally, a rationale to target and eradicate sanctuary sites of disease with radiotherapy prior to CAR-T. So we know that stroma-dense lesions impair CAR-T trafficking into the lesion, and we know that lesions that are larger and have higher FDG avidity are more likely to confer lesion-specific CAR resistance. So overall, we have moved to a more proactive debulking approach in the UK, so we use a bridging therapy increasingly. Interestingly, when we looked at our CAR-T real-world outcomes in the UK, we saw a significant improvement of long-term survival for both products when comparing the first year of the CAR-T program with 2020 and onwards, and we think that this improvement is mainly driven by better bridging therapy. So if we look at the UK AccessCell real-world outcomes in this more recent cohort, this is the PFS curve you see on the right-hand side. This really compares very favorably with US real-world data sets we saw published. So this initial concern we had that UK data is inferior to what has been shown in the US, it did not hold true. So overall, we have, particularly for AccessCell in the third-line setting, very solid real-world evidence, results from thousands of patients, to suggest that long-term remission of those who received CAR-T is around 40 to 50%. So how do bispecifics compare? Well, we have many different bispecific antibodies and small bite proteins in the pipeline, but these 4 products listed on the right-hand side are the relevant ones for lymphoma. So these are CD20, CD3, IgG type antibodies. And we now have access to glofitamab in the third-line large B-cell lymphoma setting on an EAM scheme, and also access to epcoritamab via compassionate use. The great advantage of bispecifics is obviously that they are off-the-shelf treatments readily available, so we don't have to be worried about this lengthy, complex manufacturing time like for CAR-T. But is an off-the-shelf pathway necessarily shorter and less burdensome for patients? So yes, we can treat with bispecifics straight away, but we have to remember that CAR-T cell therapy is a one-off infusion. So patients are usually discharged at day 10 to an ambulatory pathway if they live within 2 hours of the center, or otherwise discharged at day 28. We then have another 3 months and 6 months CAR-T outpatient clinic, after which they are fully discharged to local care. So at that time point, patients would still be in the middle of bispecific antibody treatment. So it's 12 cycles for glofitamab, and epcoritamab is given without fixed duration, so until PD. So it will really be interesting to see prospective patient-reported outcome data, quality of life, and specific surveys to see how both of these therapies impact on the patient experience. Where bispecifics are clearly superior is in terms of toxicity. So this is a table presented by Laurie Sen at ICML this year, summarizing CRS and neurotoxicity data for the most important bispecifics and CAR T-cell therapies. And you can see that at least for the products we use currently, axi-cel and tisagenlecleucel, the rates are much higher, particularly the high-grade toxicities. But the rate of high-grade toxicities has come down in the real-world setting. So I've put down the UK data here, so you can see that the rate of high-grade CRS for axi-cel and tisagenlecleucel is only 8%, high-grade neurotoxicity 20 and 4%, so still higher than with bispecifics, but lower than what we've seen in the pivotal studies. Importantly, what we see when, again, looking into the most recent cohort, 2020 and onwards, is a significant reduction of high-grade CRS, especially in the axi-cel cohort. So the current number is actually 4% high-grade CRS, and this is due to an earlier intervention with tocilizumab and steroids. But it's important to bear in mind that this earlier intervention is not a prophylactic intervention, whereas in the glofitamab and epcoritamab studies, they did use quite a high dose of prophylactic steroids. So I think if we would use the same amount of steroids prophylactically in standard of care axi-cel patients, we would very likely bring down the CRS rate even further and potentially also the neurotoxicity rate. CAR-T is a curative treatment that's very clear now. We have 5-year follow-up data from ZUMA-1, and you can see that there is a plateau with close to 40% of patients who receive the cells being cured. This is not yet quite clear for bispecifics. So on this slide, I plotted the glofitamab PFS curve from the New England Journal paper and the more recent update presented at ASCO this year above the respective axi-cel curves with similar follow-up. And I think what is clear is that the plateau we see in axi-cel treated patients is more convincing than what we so far see with glofitamab. Epcoritamab looks like there's potentially more of a plateau, but really very early data, and the updated curve is not showing the PFS across the whole cohort, but only the probability of remaining in CR. And we have to bear in mind that most of these patients in ongoing remission are still on active treatment. We have data to suggest that both sequences are feasible, so CAR-T first, bispecific second, or bispecifics first and CAR-T second. So on the top part, you see the forest plots regarding CR and overall response rate from the bispecific antibody trials, suggesting that there's no significant difference between patients who had CAR-T prior to bispecifics and those who did not. The bottom curve shows the PFS of patients who received axi-cel or tisagenlecleucel as standard of care third line in the French data set who had CD20 bispecifics prior to CAR-T. And you can see that the long-term survival is very similar to the total cohort. So overall, I think in the future, it will become more and more relevant to have a discussion with the patient which of these effective treatments to choose first. So if we assume we have a third-line large B-cell lymphoma, a cohort fit for both treatments, eligible for both treatments, patient not having had second-line CAR-T, the treatment decision, I think, will be mainly driven by patient's preference. So we have discussed that toxicity and the treatment pathways are very different between these treatments. So most patients will have a view as to which treatment they prefer. Some patients who progress very urgently might be preferentially allocated to an off-the-shelf bispecific antibody treatment. So we are much better now to stabilize patients with effective bridging until CAR-T. So the dropout rate has significantly gone down, but it's still around 10 to 15%. So for some patients, it will be more sensible to offer an off-the-shelf treatment. And then, of course, particular toxicity considerations, particular neurotoxicity, should be taken into consideration. But if there's from these aspects, no clear preference to one treatment or the other, I think at the moment we have to say CAR-T is the standard of care commission curative treatment, so should come first in the pathway. It will be very important to await long-term efficacy data from the clinical trials of bispecific antibodies and real-world evidence to really know whether these results are indeed comparable to what we've seen with CAR-T. In addition, we might see some subgroup of patients who benefit from one treatment in particular. So really this pathway could significantly change in a few years' time. So watch this space. In summary, T-cell therapies such as CD19 CAR-T and bispecific antibodies have truly transformed treatment options for lymphoma patients, most importantly large B-cell lymphoma and mantle cell lymphoma, and the number of licensed products and indications continue to grow. Comprehensive real-world data are very important to learn from our experience in order to optimize patient selection, bridging therapy, toxicity management, and to find the optimal sequencing for these T-cell directed therapies. A larger number of centers experienced in the delivery of T-cell therapies will allow patient-centered treatment closer to home. So overall, I think this development is very positive for our patients. Thanks for listening.
So thank you, Graham and Toby, for inviting me to talk at this Oxford Lymphoma Management course. I'm Sridhar Chaganti. I work at University Hospital Birmingham, and today I'll be talking about post-transplant lymphoproliferative disorders, diagnosis and management. These are my disclosures. So many of you will be familiar with this classification of PTLD. This is the WHO 2016 version of classification. And as you can see on the left side, PTLDs are divided either as early lesions, which are non-destructive, or polymorphic or monomorphic lesions, which are destructive, meaning there is destruction of the normal tissue architecture. And Hodgkin lymphoma is a special category. So if you look at the early lesions, these are typically polyclonal proliferations of B cells, usually driven by EBV, or almost always driven by EBV. As you can see, it's 100% EBV association. And these are the so-called plasmacytic hyperplasias or infectious mononucleosis like PTLD. And these are truly polyclonal proliferations. Polymorphic is a histologic description, but when you look at clonality, some of them can be monoclonal and some can be polyclonal, very high EBV association. And by the time you get to the monomorphic, the true lymphomas, the EBV association rate does drop down, but you still see in up to half of the patients. Majority of these lymphomas are diffuse large B-cell lymphomas, but you will see an occasional Burkitt lymphoma or T-cell lymphomas. And you will see some patients with Hodgkin lymphoma histology in the context of a PTLD. So we moved on from there to the new WHO 5 classification as it is. So this slide shows you a comparison of the previous classification with the new one. So on the left side is the previous classification, which is predominantly based upon the type of immune suppression or the cause of the underlying immune suppression. So previously, the immune deficiency lymphomas we are talking of here, not just PTLDs. So immune deficiency lymphomas were classified as post-transplant lymphomas, or those associated with HIV infection, or iatrogenic immune deficiency associated lymphomas or LPDs, or those arising in the context of primary immune deficiencies. And again, as you can see, within each of these immune deficiency settings, there are different types of lymphoproliferative diseases. Some are lymphomas and others are lymphoproliferative diseases. There is an increasing recognition that there is a repetition because the similar pathologic and biologic entities are split between different immune deficiency settings in the previous classification. So the new classification is trying to bring these together. So there is a recognition that similar pathologic and biologic entities will be grouped together, as you can see on the right side on this slide. So in the new classification, irrespective of the underlying immune deficiencies, we are classifying the LPDs based upon their biologic behavior. So we have hyperplasias, the polymorphic LPDs, the true lymphomas, and the only other specific entity is the immune inborn errors of immunity associated LPDs, some of which are specific to this particular entity. So this leads us to what is called a three-part nomenclature of the LPDs arising in immune deficiency setting. So the first bit is the histologic diagnosis, which let's say is a polymorphic LPD. The second one is viral association, if there is one. And the third one is the immune deficiency setting. So if you're talking of a polymorphic LPD, EBV positive arising in the context of PTLD, for example, or it may be a true lymphoma, it may be a diffuse large B-cell lymphoma, EBV negative arising in the context of maybe HIV infection. So that's how the new WHO-5 classification will go in terms of calling these disorders. In terms of PTLD, which is the focus of this talk, previously a number of factors have been identified as possible prognostic factors, as in poor prognostic factors were either late onset of PTLD, EBV negative tumor, a monomorphic lymphoma, and a variety of other entities. Most of these are on the basis of univariate analysis. But we have again moved some distance from there, and there is an increasing recognition now that IPI, as has been described for diffuse large B-cell lymphoma, is probably the most pragmatic prognostic factor to be used in the context of PTLD patients as well. And this is data from a UK multi-center study that was led by David Burns, my colleague here. And as you will see, the most significant factors on this univariate analysis are age, more than 60, stage, more than 3, more than 2 external sites, elevated LDH, or poor performance status, all of which are factors for IPI. So increasingly, we just use IPI as the main prognostic factor for PTLD. A lot of PTLD management is based upon small retrospective studies, but there have been a few prospective clinical trials that have really informed our practice and has made a big difference to the way we look after PTLD patients. So this was the first effort made by the German group. So this was called the PTLD-1 trial, and all patients with PTLD were initially treated with 4 cycles of rituximab given weekly, followed by 4 cycles of CHOP chemotherapy given 3 weekly. And it was CHOP without rituximab in this trial. And 70 patients were treated. As you will see, after 4 doses of rituximab, the overall response rate was 60%, CR rate of 20%. But at the end of treatment, this had improved to 90% overall response rates and 2/3 of patients achieving CR. And a 3-year and 5-year survival, as shown on this slide, are pretty reasonable. 5-year survival of around 50 to 60% in this group of patients. However, the treatment-related mortality with CHOP was around 10%. Interestingly, patients who responded to the 4 doses of rituximab had a very good survival at 1 year compared to those who did not respond to rituximab. So this led to a modification of the trial strategy to try and see if we can omit CHOP chemotherapy altogether for patients who are responding well to rituximab and reduce the treatment-related mortality that comes with chemotherapy in this immunocompromised patient group. So that led to the what is called the risk-stratified sequential treatment strategy, which was the second part of the PTLD-1 trial. 152 patients were treated on this. So these patients all received 4 doses of rituximab weekly at the beginning, and then there was a risk assessment that was done by CT scan in those days. And those patients who had a complete response were considered to be low risk, and they continued with rituximab given 3 weekly for another 4 doses. For those who did not have a CR, were considered high risk, and they received 4 cycles of R-CHOP chemotherapy. As you will see, the CR rate was 25% of the per 4 weekly doses of rituximab, with end of treatment overall response rate of 88% and CR rate of 70%. The 3-year overall survival on this trial was 70%, with a median overall survival of 6.6 years. So that kind of sets a baseline for us to develop further studies in the PTLD setting. Interestingly, further analysis from this trial showed the importance of IPI. As you'll see on the left panel figure, those patients who had a baseline IPI of 3 or more had inferior prognosis compared to patients with a lower IPI. That's overall survival we are talking of. And on the right side, you'll see the 2 figures which is showing PFS. The figure A is combined data set of the German and French PTLD groups, whereas figure B is coming from the PTLD1 trial. I would like you to focus on this dotted line, the PR patients who had a baseline IPI of more than 3. Their outcome was particularly worse compared to those who had a CR or a PR with baseline IPI of less than 3. So that led to the next trial design. So this is a study that we led in UK. This is the TIDAL trial, which is now successfully recruited, and we presented the results in ASH meeting, and manuscript is in preparation as we speak. So this trial was built upon what we learned from the German PTLD trial, but in addition, we added ibrutinib to rituximab or R-CHOP to this patient group. So all patients in TIDAL trial received first 4 doses of rituximab along with ibrutinib, had an interim CT scan in week 7, and then patients were classified as low risk if they had a low baseline IPI and achieved a PR or a CR. Patients were classified as high risk if they had a high IPI and only achieved a PR or had progressive disease or stable disease. And all patients completed treatment and went on to have response assessment scans. So patients in the low risk group continued with ibrutinib and rituximab without having any chemotherapy. Those in the high risk group received ibrutinib along with R-CHOP chemotherapy. The primary endpoint of this trial was the proportion of patients achieving a CR on the week 7 CT scan after the initial phase of ibrutinib and rituximab. And secondary endpoints included PFS and overall survival and toxicity of treatment. So 46 patients were enrolled and 39 patients commenced ibrutinib and rituximab. All 39 had interim response assessment. 16 were assigned low risk and just continued with ibrutinib and rituximab, and 23 were assigned high risk and continued with ibrutinib and R-CHOP chemotherapy. And on the right side, you'll see the baseline characteristics of the 39 patients, which is fairly representative of trials in PTLD. Around 25% of patients had high IPI disease, predominantly kidney and liver transplants. CR at 7 weeks after the initial ibrutinib rituximab was 29 to 31%, and overall response rate was around 64%. At the end of treatment, the overall response rate was 67% and a CR rate of 56%. And these are the survival from TIDAL trial, 2-year overall survival of 75%. And if you look at the bottom right panel, which is the progression-free survival post-initial IR therapy, so that excludes progressions which might just happen on the IR when the patients will switch on to IR-CHOP chemotherapy. And on this, you see the 2-year PFS of 65%, which is pretty good, but not really much of an improvement compared to what we have seen in the German PTLD1 trial. So we've also done a comparison of patients who received rituximab monotherapy with patients who received R-CHOP chemotherapy. So this is a multi-center UK retrospective study, once again led by David Burns, who works with me here. And this was retrospective, so patients were chosen to receive R-CHOP or R monotherapy upfront by treating physicians based upon their perception of risk of the patient. And as you will see, we had 40 patients receiving rituximab monotherapy and 58 patients receiving upfront R-CHOP chemotherapy. And those are the response rates of the patients as shown on this slide. Interestingly, when we look at a low risk versus high risk IPI PTLD and comparing R monotherapy versus R-CHOP, shown on this slide is for the low risk PTLD, there was no difference in either overall response rates or CR rates or the 3-year survival, which is around 75 to 80% for this group of patients. So they do very well. Even with our monotherapy, there is no benefit of giving R-CHOP chemotherapy if you have low risk IPI. If you have high risk IPI, it is slightly different. As you will see, the overall response rate was significantly better, or nearly significantly better with R-CHOP. And the CR rate was definitely better. In fact, 3 times more patients are achieving CR compared to rituximab monotherapy. However, the 3-year overall survival is in fact inferior for patients who started upfront R-CHOP chemotherapy compared to those who started with rituximab monotherapy. So there was no survival benefit of starting with upfront R-CHOP chemotherapy. And this shows the survival of patients on this retrospective study. Overall survival, the median overall survival and progression-free survival is more than 6 years for the entire cohort. And as you will see on the bottom 2 panels, IPI remains highly relevant. And on the right panel, you'll see survival of patients with low IPI compared to high IPI. And that seems to be a very important factor in determining prognosis for these patients. So we also compared rituximab monotherapy versus R-CHOP to see if it has an impact on survival for these patients. But even looking at the bottom 2 panels, where we are comparing with IPI, there was no difference between rituximab monotherapy or R-CHOP chemotherapy. So we conclude that starting upfront with R-CHOP chemotherapy does not really improve outcomes for these patients, though you will achieve better CR rates initially. This is a study that we did a few years ago now to look at PTLD arising post stem cell transplant. We had 62 patients with PTLD following stem cell transplant, 46 biopsy confirmed, and another 16 were highly probable based upon quite robust clinical and radiologic data. So these are all patients with stem cell transplant. And we had 51 patients who were evaluable for response. 3 patients just received reduction in immune suppression. Majority, 47, received rituximab monotherapy that's given weekly. And as you will see, for rituximab monotherapy, around 33 patients achieved a CR, so around 70% CR rates with rituximab monotherapy. A minority of patients received rituximab and chemotherapy. Most of them did not respond. Almost all of these patients died, unfortunately. And 6 patients received donor lymphocyte infusions with a decent response rate in these patients. Typically, most patients would have received chemotherapy or DLI after having not responded to rituximab monotherapy. We also have data on EBV CTLs. This can be used in the context of a EBV positive PTLD. So this is data from a study led in the US using third-party derived EBV CTLs. Shown on the left side are responses in patients following allogeneic stem cell transplant or solid organ stem cell transplant. And as you will see with the cycles of EBV CTLs are typically given weekly in cycles because these are allogenic third-party donor-derived cells. They don't survive as well as autologous cells do, so they are typically given in repeat doses. And as you will see, response rates have improved in these patients with repeat doses, and survival typically around 60% for both stem cell and solid organ transplant patients. And on the right side, you'll see a figure A, which shows that patients who achieve a response have a very good survival at 2 years. Even stable disease surprisingly had durable survival or durable remission, but patients who do not respond or progress on CTLs have a very poor outcome. So this has been taken forward into a trial, which is called the Allele trial. This product is now called tabelecleucel. It's the same EBV CTL product. So the Allele trial has recruited patients, both stem cell transplant and solid organ transplant patients, and has delivered EBV CTLs in cycles. Each cycle is 5 weeks. Patients get 3 doses of treatment in each cycle. And the primary endpoint for this study was overall response rate. And we have data on about 50 patients treated on this trial now, and the overall response rate, PR plus CR, is around 50%, with CR rates of about a quarter of patients treated. And we do have survival data, which is around 80 to 90% of patients who have achieved a response are alive at 1 year time point. It's not there on this slide at the moment. So we conclude that this stratified sequential treatment strategy is currently become standard of care for treatment of B-cell PTLD after solid organ stem cell transplant. For stem cell transplant, we would suggests that chemotherapy is probably best avoided. Rituximab monotherapy remains standard of care for established PTLD. Chemotherapy confers very poor outcomes for these patients. Third-party donor-derived allogeneic EBV CTL therapy is showing promising results for patients with EBV positive PTLD who failed rituximab with or without R-CHOP chemotherapy. For EBV negative patients, there are very limited options at the moment if they fail rituximab or R-CHOP chemotherapy. But in recent years, CAR-T therapy, there is emerging data on the use of CAR-T therapy in these patients. So thank you for listening, and I'll stop my talk there.